summer is coming, as is the Platinum Jubilee celebrations. So delighted to see members of the public with us today. And because this is a bank holiday week, we have some colleagues on holiday. So Anne Coyle is on holiday. She sends apologies, as does Harkamel. And our colleague Fiona is unwell at the moment. So Fiona, if later on in the day or over the next few weeks you're watching the recording, all of the board wish you well. So delighted that Claire and Ellie are joining us today to represent Harkamel and Fiona. Have we any new declarations of interest? If we have, can we please raise a digital hand? David?
Yeah, I've just been appointed as an expert advisor to NICE on their guidelines panel.
That's very prestigious, David, and congratulations. So thank you for that. Any other new declarations of interest? Please raise a digital hand. Okay, so we'll move on then to the last set of minutes. Was everyone happy with the accuracy of those minutes? If you weren't happy, can you please raise a digital hand? Can't see any digital hands, so I'll take those as an accurate reflection and we'll sign those. So we go to the action points arising, which are on page 18 of the pack. And the first was, under Glenn's report, an invitation to be sent to Sarah Woolley at Warwick Business School to attend a board workshop session. That's been done and is scheduled for October, so looking forward to seeing her then. And then on the integrated performance dashboard, Fiona to provide a reflection on the reasons for the reduction of births of the midwifery-led unit. We've deferred that in the circumstances until July. And then to ensure a deep dive on the reasons for staff leaving and to amend the method of workforce measures to annualised rather than monthly. Gertie, where are we on those, please?
Yes, Chair, we're undertaking and starting a very deep dive to understand the real hotspot areas, and I've asked the team to review how we report and return turnover itself. I would hope that that would be updated for next month, but at the very latest that it would be for August.
Okay, thank you, Gertie. And then we talked about a women's menopausal network to be set up or be provided when available. Gertie, where are we with that one?
Again, Chair, it's in the health and wellbeing update later. Menopause has been identified as one of our top 5 priorities from a wellbeing perspective, and we will be sharing information as and when it comes online, either through ourselves or the work we're doing at system level.
Okay, great. And then Kim was to circulate a breakdown of agency staff, which Kim kindly did. So thank you for doing that, Kim. And I think that was the end of the action points. If I've missed an action point, please raise a digital hand. Okay, so we move on then to the substance, and the first is the trust name change. Glenn, can you please brief us on where we are, please? Thank you.
Thank you, Chairman. Yeah, quite well, really pleased to be at this point with this issue, because this is obviously culmination of quite a lot of work. I noticed Simon Brake has joined us in the background in this meeting. There he is. Thank you to Simon for the efforts that he's put into bringing our research strategy into the position it's into now, which I'll talk about in a moment, and assisting us and aligning us with the university, and now also taking on a role to promote our research across the group and to raise our game, which is what we've already done, but we will do quite a lot more of over the next few years. What this paper does is sets out the responses to the engagement that took place regarding our name change. And we started off with the proposition of moving to be called Warwickshire University NHS Foundation Trust. But actually, on listening to engagement and proof that it was a real exercise, we have we've changed that and added South back into the title of the organisation for a number of reasons, which are set out in this report. I mean, one of the main things actually for me is that Swift is a great brand and a recognised brand, and so putting the university bit in there is something that we can do moving forward. What that change also allows us to do is to retain email addresses, and what I didn't want to do with this change is make it something that added cost or effort across the organisation. So staff don't need to change their uniforms until they need to change their uniforms, and then we can accommodate it then. So the response is set out there, and we are to avoid too much work and cost. We're going to make this change on the 1st of August. The build-up work for that has already started, and there's a little working group which Chelsea, mine and Russell's PA is working on, and it's all falling into place. But then also we provide an update on where we are with the research strategy, and I won't go through it all, but we put some more investment into some roles and some leadership roles, including Simon's, and I'm really pleased with the way that's shaping up, and some good conversations with the research network, and we'll talk more about this in the future. And then finally, and we tied this in to the name change. We've been doing some work. Gertie has been leading on this, looking at the trust values and checking in to see whether they are still appropriate and relevant to our workforce, which overwhelmingly the response was that they like our safe, effective, compassionate, trusted values. They live them, and staff created them in the first place. But the thing that we decided with their advice that we needed to be more visible on was the inclusivity agenda. So as you can see from that picture at the bottom of the page there, we've added inclusive into there explicitly, to recognise some of the work we're doing on that and our intentions as an organisation. So we'll make these changes together with the way that we brand the organisation. So happy to take any questions on any of that, Chair.
No, that's great. And can I just add my thanks to Simon and Anne Cora, who have worked with Meg comprehensively behind the scenes to make all of this happen. So thank you. And also just to, we did have feedback from some of our community colleagues in North Warwickshire, saying that they were a little disappointed that we'd kept with the name South Warwickshire. But like most things in life, it's about finding the balanced way forward, and we do think this is the correct way forward. Any questions to Glenn on that paper? Okay, I can't see any digital hands raised, so thank you for that briefing, Glenn. And we look forward to the 1st of August. So we'll move on then to the review of the Trust Constitution, including the annual review of board standing orders. Sarah, over to you.
Thanks, Russell. So this follows on from Glenn's report. The Constitution's been reviewed to reflect the proposed name change, and the amendments are shown as track changes. This was considered at the Council of Governors meeting on the 12th of May. Usually we would submit to board first and then Council of Governors, but because of the timings of the meetings, we've done it the other way round. And there's also proposed amendments to the board standing orders because they were due for an annual review. There will be a more detailed review of the Constitution in due course, but we wanted to propose the amendments around the name change so that work could be progressed. So happy to take any questions. Thank you.
That's great. So not very controversial, these changes at all. Any questions from colleagues? Okay, if you're not happy to approve, please raise a digital hand. Okay, duly approved. Thank you, Sarah, and thank you for your work behind the scenes. And Sarah's role is expanding, obviously, with Meg leaving us. So, Sarah, we wish you well in the new role. It's an exciting period for you and the whole of the Trust. We'll move on then to the DSPT assessment. Charles, please.
Yeah, Well, the paper now reads that we've actually met all the targets, and I would just like to say there's a huge amount of work that underpins this process, and the bar raises every year. So, you know, hats off to Vicky and the team, and indeed our IT colleagues who've got all through all of these standards. Really, I don't think apart from saying that the standards are now met, there is really anything else to add.
Thank you, Charles. Just to put things into a degree of context, Charles, are all trusts in a similar position to us?
I can't give you any hard figures on that, but my understanding is that there are several who aren't compliant with all the standards. So actually getting the full compliance, you know, is really quite an achievement.
Okay, thank you, Charles. Any questions or perspectives to Charles? Phil?
Charles, did the last penetration test occur end of May? Okay.
Yes, that's why we can report full compliance.
Brilliant.
Okay, that's great, thank you. If you're not happy to approve the paper, please raise a digital hand. Okay, duly approved. Thank you, Charles, and please send our thanks to Vicky. We're then on to the highlight for many of us of the monthly cycle, the Chief Executive's report. We're on about page 103 of the pack for those of you on the digital system. So Glenn, over to you. How are you seeing things?
Thank you, Chairman. I haven't got my corporate football manager logo thing behind me like you have, because I was waiting actually for them to raise the Union Jack. The NHS blue flag is coming down for just a few days, and the Union Jack going up behind me. So that's why I've not got that up. So what's going on at the moment? Lots, as I always say. Firstly, the Health and Care Bill is moving forward to the 1st of July implementation. And the press release that came out when that bill gained royal assent only included 2 examples of great integrated working, and we were one of them, which was really great to see. A lot of work going on in the background on that, which we'll continue to brief board on. We've also stood down from a national level 4 incident, and for the best part of 2 years, we've been at that state of alert across the NHS, and a degree of command and control has been necessary during that period. And so I'd like to thank those staff that have manned our incident room 24/7. The pressure isn't quite off actually, because we've moved down to a level 3 regional incident, and we also have a state of readiness around the Commonwealth Games coming into the area as well. So there's quite a bit of stuff going on around making sure that runs smoothly as well. But it's nice to see that we've moved into a bit more of a business as usual mode. I then talk about the elective recovery plan and the IPC changes. This is an extract from a presentation that I gave to the Midlands Chairs meeting, where we're talking about the elective recovery position of the region. As I chair the Regional Elective Recovery Board, there's some really important elements to this which we need to keep an eye on as an organisation. The first of which is the outpatient transformation element of recovery. A lot of the focus has been on the patients that come in for surgery. But actually, if you look at NHS waiting lists, only 3% of the NHS waiting list are operative. Around 20% are having procedures in day case or outpatient setting, but the bulk are actually in outpatient pathways or diagnostic pathways. So making sure that we look to how we can transform them is really important, and we're going to be doing a little bit of that, which I'll refer to later at our 3 boards meeting. Managing urgent care, we've talked about. Validating waiting lists, supporting patients on the waiting list to wait well, building capacity. Obviously, we've got our own plans to expand our capacity here, yet haven't been funded from national capital, but we are still knocking the door to see if we can get hold of some capital or approval to spend capital. And then productivity and efficiency, and some of the work that we've been doing locally on that also. And it's great to see Professor Tim Briggs talking to the regional chairs meeting, who leads the National Girth Programme and who often references the work that we've done here. In fact, our orthopaedic team fed into a national webinar on girth, looking at some of the improvements that they put in place to length of stay, which is really impressive. There's been the appointment of the NHS Chief Strategy Officer, so Chris Hobson, who joined our last 3 board development session, who was Chief Exec of NHS Providers, has been appointed into that role, which I think is great because he understands the NHS, particularly the provider side of the NHS, but also has been very much aligned to us and our strategy. So I look forward to him starting in that role soon. And then I refer to the quarterly parallel board meetings. So from August, we will hold the 3 board meetings together. They're still meetings of the individual boards, but what we're going to be doing there is doing some comparative performance, looking at a new integrated performance dashboard, which is common to all 3 trusts, looking at productivity led by the finance directors, looking at some of the girth data within that and the model hospital, and then drilling down into something specific. So in the very first meeting, we will have a look at outpatient follow-up ratios, and we will have a look at elective cancellations linked into some of the objectives that we've set around Operation Ring Fence for the organisation. I then talk about agile working and how we are not going back to a situation where we expected people to travel to lots of meetings that could take place using technology like the one we're using today, but we will have face-to-face meetings, but we'll balance that moving forward. I then talk about inflation impact on the NHS, which Kim will reference when she gives us the finance report later. It's good to see we've had some contribution towards inflation. We've not had any contribution towards capital cost rises, and that's something I have raised with the National Finance Director. And the way that inflation has been applied to trusts has been basically on a kind of self-reporting basis rather than a fair shares allocation, which we'll need to keep a careful eye on, but at least it has improved. And what it's done for our position is moved us from a planned break even to what will have to be a planned surplus in order to ensure that that allocation has improved the overall bottom line of the system. And then there's an update on our nurse-led outreach team, particularly some of the work that our teams do. The street outreach team's absolutely fantastic, and talk about our priority of tackling inequalities. If you look at some of the groups and some of the hard-to-reach groups that have been supported by those services, it's really impressive stuff. So that's all I wanted to highlight, Chair. Happy to take questions.
No, very comprehensive, Glenn. And I think probably just the one thing I would brief members of the public on, in addition to what Glenn has said, is the system locally is still under very real stresses in terms of ambulance handover times. And in particular, our friends at Worcester are having a torrid time. So we've again offered the hand of friendship to Worcester, apart from the intelligence conveyancing that, if you like, naturally happens through the West Midland Ambulance Service. We are encouraging them through their position as an associate member of the foundation group to use the experiences we've had to help them. Questions or perspectives to Glenn? Glenn, just to sort of contextualise things for members of the public, how much do you think capital inflation could affect us this year? Are we talking a 500,000 problem, a million problem, or a number of million problem?
Yeah, I mean, so we are speculating to a degree, but I'm already seeing some of the, and elsewhere in the group, actually earlier today, I saw a capital project come back that's got probably around a 20% uplift on what we were expecting. So I think we're in that territory, which for us would be a couple of £1 million ish. on our capital programme. And I suppose, and the question I put to the centre is, do you want us to pare back some of that capacity, or do you want to ensure that we deliver that capacity and obviously top up the cost of that? So Sophie might have a view on it, but it feels in the order of around 20% at the moment. Sophie, do you want to correct me?
No, it's just to say, yeah, the market is so volatile at the moment as well. So a couple of years, even 18 months ago, a project that would have cost 4.2 million, we've tendered and it's coming back at 10. We're really seeing big increases in some of the modular builds because a lot of people are going for those. And just also, yeah, about 20%. So we have added a small percentage on our capital programme. We're going to have to see as the year progresses what we can and can't pursue in the realms of what we've got approved. So it's really going to be an impact this year.
Thank you, Sophie. And Simon, and then we'll move on.
Thank you, Russell. Glenn, the step down from level 4 to level 3, is that in terms of COVID protocols and things, what we agreed several weeks ago, or is it additional loosening of our protocols and therefore will help with flow?
So technically, it simply removes us from a situation where we were being told what to do, managing the incident from a national perspective into a more localized regional control arrangement. And yes, that embraced a whole range of things, including infection prevention guidelines.
Yeah.
There's been some loosened guidelines that have been issued more recently, which we've responded to, and those are still in place. But I hope that we start to ease back into a situation where we're back into kind of making local risk-based judgments on those kinds of things. I think it's probably fair to say the centre do quite like to be in command and control mode. So the sooner we're back to business as usual, the better.
Yeah, sounds good. Thank you, Glenn.
Absolutely. So if colleagues are happy to move on, I think, Kim, you're doing the introduction today. Am I correct, to the integrated dashboard in Anne's absence?
I am. Thank you, Chair. So just a few highlights before we introduce colleagues. So pleased to see that the majority of our quality and safety KPIs are within the normal control limits, and that our incidents relating to discharge continue to decline. Inpatient falls with harm remains low, and we also continue to demonstrate a positive reporting culture. We continue to escalate concerns to our partner organisations with the high number of children that are presenting at children and young people that are presenting at ED. We still have a high number of attendances at ED, but we have been able to maintain a stable performance against the 4-hour target of about 67.3%, which means that we remain at the top sort of quartile. We've got no patients waiting over 104 weeks, and we have 24 patients waiting in excess of the 78 weeks. And that target was supposed to have no patients waiting by the 1st of April 2023. So we're making good progress on treating those patients. Pleased to say that we are diagnostic performance in Coventry and Warwickshire for 6-week waits is the best in the UK, so that's really positive. In terms of elective recovery fund performance, we didn't achieve the target of 104, but we did do well at achieving a 90% performance, which is still really positive. I'll talk about the financial implications of that later on. In terms of people, again, we've done really well with appraisals, with more than three divisions exceeding the 85% appraisal target, and all divisions achieving the 85% performance target on training. So that's good progress. I'll talk about the finance a little bit more in my section, but otherwise I'll hand over to my colleagues.
Thank you, Kim. Thank you for taking the lead on that introduction. Should we move into the detail, or Charles, did you want to make a point first?
Yeah, just make a point, because I think one of the important figures there is the elective recovery target. And I think it's just worth pointing out that 2019, which we're comparing it to, was a bumper year with, you know, an extra operating theatre that was staffed. Currently one of the biggest constraints is actually theatre staff. And relative to others, our 90% is good, but there's a lot of effort going into it. But it's a hard 104 is a very high ask.
Thank you, Charles. Glenn, did you just want to add to that?
Yeah, I was just going to add to that. The methodology of calculation of the elective recovery fund is a bit complex, and we've been talking to the national team and looking at that baseline. As Charles says, because we've always done a high level of activity, it set us a high baseline. But we're actually delivering 108%, I think it was, on inpatient work, so that's still pretty good. What's dragged us down quite a bit is outpatient activity. The way that the formula works is you're capped at 85%. For follow-up activity, so you can't really generate the level of income through outpatients, particularly for us, because we've traditionally had a very low new to follow-up ratio, i.e. we see more new patients and don't follow them up unnecessarily, which again gives us very little flex in ability to convert follow-up slots to new slots and do more activity. So we're up against it. It's much easier in organisations who traditionally haven't done much work to deliver the 104%, but we are where we are.
I think that's absolutely right, Glenn. There is a perverseness about the way they are doing it, but as you say, we are where we are. Colleagues have to move on to the nursing report. Ellie, first of all, can I say on behalf of the team, thank you very much for the way you're standing up and supporting in Fiona's absence. It's greatly appreciated. I know it does put an added burden onto you and the senior nursing team, but first of all, thank you very much. So Ellie, what would you like to pull out of the report?
Thank you, Chair. The corporate nursing team are really happy to support in any way we can under the circumstances. So what I'd like to highlight really is the assuring reduction in discharge incidents, which I think reflects the sustained work being done by the head of nursing for emergency with multidisciplinary colleagues to improve our safer discharge. So that's really assuring. In addition, our medicines incidents have gone down, but I'd like to thank the board in advance of June. We've got our medicines board toward where we'll all be helping to embed lessons learned from incidents and key messages, so that's great. And our falls from harm are down, which again is reflective of a rollout of falls training and competencies and enhanced presence of our falls lead in clinical areas.
Thank you, Ellie, and it was great for David and I to join you yesterday on our visit to the specialist care baby unit and meeting Jennifer and Sasha and the rest of the team. Some wonderful work going on, and we'll maybe touch on it again later, but I'd just like to reiterate I'm extremely proud of all of our midwifery and baby unit teams. We do phenomenal things at Warwick, and we should recognise that and thank everyone for their hard work. Any questions to Ellie, please raise a digital hand. Sue?
Yeah, hi Ellie, thanks for the report. It was really pleasing to see that the respect form incidents are right down this quarter. Is that something strategic that's changed? Do you think it'll continue?
I do hope it will continue. It is part of the training now in terms of news and resuscitation. Annual training also covers respect form and the importance of making sure it goes with the patient. We've got some processes in place as well to follow up if it unfortunately doesn't, to ensure it gets to where it's needed. So I speak to the resuscitation officer regularly who picks these up, and she feels fairly assured that it seems to be improving and sustained at that.
And Sophie, did you want to add something to that?
Yeah, not a question, actually, just to add to something else in the report, Ellie. So just around children, young people in crisis, just to make the board aware, we have been given the opportunity to feedback on the Partnership Trust strategy. And so as part of that, as an exec team, we will be making sure that we cover off some of the concerns we've had discussed at board. I just thought it's helpful for the board to be aware of that.
Thanks, Sophie. And Charles, did you just want to add something?
Yeah, just add on the respect form, there's a constant push, with the medical staff to raise awareness, etc. And certainly we seem to have a sustained improvement in the number of forms that are completed. But I think the next stage is to try and improve the richness of the discussions and the the quality of the information that goes on them. So it's still a work in progress.
Well said, Charles. Thank you, Sue. And Rosemary?
Yeah, Sally, in the report you refer to the arrivals into A&E from people from outside South Warwickshire, particularly from Birmingham and Solihull. So can we have comfort that we will get paid for this activity and that there are appropriate steps in place to be able to actually monitor and record that, so that if we do get paid, we get appropriately reimbursed?
I think Glenn just put his hand up for that, so I'll let him go in.
Yeah, I mean, Kim,
Ellie, is knowing when to answer the question and when to delegate upwards. So well done. Glenn?
Probably it was a fight between me and Kim as to who answered that one. So, yeah, I mean, it's a worry. I mean, obviously, when we look at the Chief Operating Officer's data as well, we look at, a deterioration in the A&E performance and high levels of A&E activity. But actually, in addition to that, there's a lot of activity that now goes straight into our frailty unit, into our same day emergency care, as it doesn't even go via A&E. So it's a problem. And we've highlighted that with Birmingham and Solihull system. It's actually 65% up year on year. And that material is about £1 million worth of income if we were paid for it. At the moment, we are not being paid for it, and Kim and her team are pushing to get that recognised, because I think this is a pattern of activity that's going to continue, and we therefore need to build our system to be able to respond to that. I mean, whilst we're doing relatively well, 25th in the country on A&E performance, we're nowhere as good as we were in the past, and I'd like us to build that capacity so that we can get back to that position.
Yeah, no, it's a very, very difficult issue, isn't it? And one of the things we need to watch, because it is being seen in some quarters, is there is a seductive narrative of actually, if you do less, you will make more profit. Because of the way some of the contracts work. I want to make it clear to members of the public, we will be very, very focused, even if it hurts our finances, on driving down our waiting lists and continuing to improve our A&D performance, because that's what we exist to do. We don't exist to make a profit, albeit we are one of the most efficient organisations in the NHS. We exist to serve our citizens in the best way we can. So if colleagues are happy, we'll move on to Claire. Thank you, Ellie, who's standing in for Harkamel. Claire, over to you. What would you like to pull out of your report?
Hello, everybody. Just a few areas to highlight. Obviously, A&E performance, yes, at 67.3% during April, a slight decline on previous months, but this still places us at 25th out, a move from 23rd last month, but amongst type 1 providers and still above the 75th centile. No trust achieved above 90% nationally. Attendances remain high, with Mondays and Tuesdays the highest in the week. As many of you are well aware, flow remains a challenge. Medical bed occupancy reached 96.2%. And as you've alluded to, Russell, the ambulances, they are steadily coming through. But a project in the Frailty project with WMAS has seen around 100 ambulances and patients who were not conveyed to the hospital. Overall, RTT performance reduced by 2%, but we remain in the upper quartile for performance. As a reminder, the focus is on our very long waiters. The positive news is that the number of trusts' longest waits have reduced once more, with 24 waiting over 78 weeks and no patients at end of month waiting over 104 weeks. Our diagnostic performance declined further in month to 93.2%, the lowest this measure has been since August 2020, with a total of 6,327 on the waiting list at present. However, for note is that Coventry and Warwickshire as a system have the shortest waiting times in the country at present. And in addition, we are reporting a reduced backlog, which is now reduced to 5 days to mitigate those figures. And lastly, the highlighter around cancer performance, it remains stable, and the 28-day faster diagnostic standard, which is now the key measure, achieved 70.8% against a standard of 75. As Glenn has mentioned, our A&E ED performance has been challenged. The numbers that we are seeing day by day are in the mid 200s, and real challenges as our exits, if you like, our delays within both acute and community hospitals remain at a high number, around 85 at the end of April. This includes patients from Solihull, Gloucester, Birmingham, and some of the increases potentially stems from our problems from those delays and other facets within community services impacting on the flow throughout inpatient areas. So that's my briefing at this point.
Oh, that's great. Thank you, Claire. Questions and perspectives, Glenn?
Thank you, Claire. Well done on the cancer performance. As you say, that, I mean, the A&E attendances, I remember when I first arrived, and I know it's a while ago now, before anyone else says it, that it was about 150 attendances a day, and now it's 250. You know, it's quite a significant jump in A&E activity. The one thing I just wanted to point to is just to say a huge thank you to the orthopaedic team, who have been, obviously they've been in a good position on waiting times, but their mutual aid offer to other systems has been brilliant, and really positive feedback from Y Valley, front page of the Hereford Times, appreciation. They actually went out, so patients came over here for their orthopaedic treatment, and then our team went over to Y Valley to do follow-up clinics there for those patients, which was great for those patients, but also the orthopaedic team at Y Valley then joined our team and looked at how they do follow-ups and spread the learning about some of those processes that they put in place, which is great to see. So well done to orthopaedics.
No, absolutely. And David Spraggett, please.
Yeah, my question, I might have missed it in the data, but have ambulance handover delays improved from previous months? I know that the activity is still high, but I just want to be reassured that we're managing the risks of the delays in handovers that we've had in the past.
And Glenn,
yeah, I mean, Claire may want to give some numbers, but just to because I'm about to not give you numbers on that day, just to reassure you, there's an hourly report that goes to every chief exec, which throughout the 24 hours of the day, that I monitor quite closely, and we never appear on the longest delays on that. We do have some over 60-minute delays, generally lower numbers than any other trust. But we want to ensure that we don't have any of those, so we just keep an eye on it. As Claire said, there's particular times of the week. Mondays and Tuesdays are higher. There are issues around the way intelligent conveyancing works. So if we are turning ambulances around quickly, we are more likely to get more ambulances because they will come to us rather than go to some of those sites that are struggling. So so it's something that can change quite quickly in the course of the day, actually. But I don't know whether Claire's got precise numbers, but as I say, we're certainly one of the best performing in the Midlands on that.
So apologies, Dave, I haven't got exact numbers, but I can send some through to you next week if that's okay.
Yeah, that'd be fine. I mean, I'm just mindful that I know because I've seen it, we've got a robust policy in place for how we manage the risk for people within the ambulance waits. And I'd just be interested to know, numbers and indeed whether we're actually following the process as we've planned, because I think this is a risk all over the country, I know, but I'd like us not to be in the headlines for the wrong reason.
Right.
Can I suggest, Chairman, we do a little bit of a feature on that next time, just so we can provide a bit of data and set out how we're performing as an organisation, and pick up on David's point about what we do if we do have delays.
Yeah,
great idea. That would be good. Thank you. It's also worth mentioning to members of the public that in the main, handover delays at A&D relate to the problems trusts have with medically fit for discharge patients taking the available bed stock. And the real focus needs to be on discharges. And if the focus and the success of the discharge programme increases, that frees up the flow of beds through the hospital and therefore makes the A&D department able to transport on patients into a hospital bed faster, which makes the ambulance delays less. So you might think the problem is in A&D. In reality, the problem is at the other end of the flow, and it's around discharges. That is correct, Glenn. Do you concur with that? Okay, super.
Very good description of the problem.
And Sue?
Yes, my question was linked to that. In terms of stranded patients where we've been trending upwards along with the rest of the country, do those Solihull urgent requirements that we think are long term, do they require us to start to work or build similar sorts of practices as we do with Warwickshire in order to get patients home or out of the beds in the hospital?
Yeah, that's a good observation, actually. So the evidence shows that patients from out of area, which those would be, are generally harder to discharge and generally feature in some of our stranded and super stranded numbers. So if we can establish that this is a pattern that's going to continue, we can build closer links to assist discharge. Ideally, getting access to discharge to assess capacity in Solihull for those patients. So yeah, it's a problem that we, as I say, if we can establish it's going to happen on an ongoing basis, we can make it work more smoothly for those patients and get them home more rapidly.
And our discharge to assess beds, Glenn, just to use an analogy, are a wee bit like us having a small Premier Inn, which allows us to take patients who don't really need to be in an acute setting into a transitional setting before they're able to get home.
Yeah, I wouldn't want to cast aspersions on Premier Inn, but it's high quality clinical input in addition to the facilities that we put them in, which is more of a care home setting than being in an acute hospital, which is inappropriate.
I'm certainly not recommending Premier Inn as a place for hotel accommodation. Colleagues, happy to move on to Gertie then. So Gertie, how are you seeing things on the people front, please?
Thank you, Chair. I'll try to just pull out the key points. Recruitment, as colleagues won't be surprised to hear, remains a key focus for us and one of our highest risks. We are continuing with the fortnightly task and finish groups between myself and colleagues in nursing, and Ellie has been hugely supportive in that. We are seeing some improvements in the approach to nurse recruitment and clinical support worker recruitment, which we picked up in more detail last month. In terms of this month, there's been some positive progress with a number of new starters across nursing, midwifery, clinical support worker and AHP disciplines, and also appointed 4 international nurses, which is positive. There's a bespoke piece of work going on about our international recruitment at present, and we have a number of recruitment events planned over the coming weeks and months. Sickness has increased slightly in month, up to 6%, does remain significantly below our highest peak that we experienced through the pandemic. There was a huge, significant amount of support being put in place for those areas that need it. We're still seeing the highest reasons for absences being infectious diseases, which would include COVID and stress and anxiety. And as I said, support for both of them put in place and through the FPE discussions. Appraisal and core skills training framework. It's positive to see that all divisions are above the 85% for their core skills framework training. We've seen some really positive improvement in appraisal compliance. If you recall, this was an area that we stepped down a number of times throughout the pandemic to enable our staff to focus on provision of frontline care, and those 3 of the directorates, the divisions, have improved significantly over previous months through the review and the reporting in Finance and Performance Executive Committee, and the others all have detailed trajectory plans. Happy to take any questions, Chair, but I hope that covers most of the areas. I'm happy to pick any questions up.
Thank you, Gertie. So questions and perspectives, Glenn?
Yeah, just as Gertie said, a lot of focus on HR people issues at the moment. There's probably, it's great to see the recruitment numbers in a positive position, but retention is obviously an important focus for us also. We're also looking carefully at how we can ensure that our nurse bank particularly works effectively to reduce the amount of agency spend, and we approved a business case on that a couple of meetings back, but making sure we get that working well is important. And actually, one of the other things that we're turning attention to is hardship and supporting staff who are in financial distress, and that's something that we're giving careful consideration to what we can do as an employer on also. So quite a lot of kind of core HR issues at the moment that we're spending time on.
Thank you, Glenn. And David Sprague?
Right, yeah, mine's also related to retention in one way. I'm just interested in the number of leavers and how many of them are people who are retiring early, because I think retention of people who are at the experience end of the work spectrum is really important. The data doesn't actually let us know. I mean, there could all be 78 leavers last month that happened to have only started a year ago, which perhaps wouldn't be as catastrophic as if it was 78 that have been working for us for 30 years. So I'm just interested if you've got any data on that. I'm sure you have.
Yeah, so I think I said at the start of the meeting, David, I've commissioned one of the teams to do a really deep dive into understanding our turnover, so we understand some of those trends, and we will report later in the year a more detailed analysis into board. We do have some of that information because we record in the main reasons for people leaving. Retirement return, we do see some of it, but we haven't seen at the significant increase we were expecting. You're absolutely right, though. I mean, retaining those staff who make decisions about retirement or wishing to do so flexibly or retirement return is really, really important, and I'm asking through the retention work, and Ellie might be able to speak to some of the great work that Vicky has been doing, that we make that as supportive and as easy as possible, and that we shift our cultural approach to why do we do this and how do we accommodate it, to very much to why wouldn't we, how do we retain that knowledge, that experience in the organisation. So lots of work going on around retaining colleagues through all the spectrums, and as I said, Vicky is leading a piece of work about early career, mid-career and late career, and we are focusing on what we can learn on that. We're actually a pilot organisation for the national toolkit, which we expect will be available in July.
Thanks very much.
Thanks, David. Thanks, Gertie. Rosemary?
Yeah, and a massive focus on agency, which is really important. But I'm hearing NHSEI obviously coming back with new requirements to reduce agency, but there's also reference to bank as well, and so I'm a little concerned. I don't know what that means. but all the work that we're doing to try to make bank more attractive, we just need to be careful that that is also going to be in line with any of the NHSEI requirements. And obviously getting substantive people in post is absolutely key.
Yeah, you're absolutely right, Rosemary. The first solution is our own substantive recruitment. At the moment, we are trying and working with the bank to improve that, and we are working on the rules that NHSEI have had in place for a number of years. Obviously, if they amend or increase over coming months, we will work with that as new national guidance comes out. But we are definitely following the approaches that are required of us at the moment.
Glenn, did you add something to that?
Yeah, I think some organisations manage this differently. What our approach is that additional hours go through our bank rather than through payroll. And so I think NHS England probably just need to, I'll be discreet, probably just need to understand the issues a little bit more before they issue such guidance. What we will do is use our bank to encourage staff to work flexibly and to work additional hours, because our staff are better than agency staff, and that's the right way to work.
My observation would be there's going to be no silver bullet to this issue. I think that we know a couple of things. We know demand for our services is very high. That's evident from the waiting list. And related to that, we know as a team and as an organisation, we are more productive. We can be more productive than others. The second thing we know is that financially this year could be ruined by agency costs. But agency costs are a symptom of us having to get hours to provide safe staffing levels. It is my opinion we have a window of about 2 to 3 months before we hit the summer, and certainly before we hit the winter, to have in place ways for us to ensure we shift the use of agency hours into bank hours. I would far prefer my substantive staff to be being paid overtime than it to be going to outside agencies. And I think the second thing is we need to find better, simpler, more straightforward ways to allow nurses in particular who are retiring to get re-employed with us. It's a minefield for nurses who retire to come back to work part-time. We must find ways of making it easier. So I think, Gertie, we've done some phenomenal work recently in terms of what I would describe as HR strategy and the future. The values work is brilliant. The work we've been doing on inclusion is brilliant. We now need to get really operationally practical and find ways of helping Ellie and the frontline teams to get those hours in without it being paid at agency rates. Ellie, is there anything you wanted to add to that?
Yeah, just picking up on your points about retirement. So myself and Gertie have already started that conversation, and it will feed into our retention work and our clinical retention work streams. So we have picked that up already. And we're also doing a piece of work about people that are working on our bank currently, about getting them into flexible working contracts as substantive staff. And we've already transferred quite a few people over that way. So our new clinical lead for retention has done some really good work there as well.
That's great to hear, and great to hear the pace of you and Gertie, joining up the dots. But I can't encourage you enough. It's about pace of action at the moment, because otherwise we'll be looking when we get to the half year and Kim will be saying the numbers are looking very bad. We've got this short window of doing stuff, and now is the time to act. Try some innovative things. They may have a type of risk profile which we wouldn't traditionally take, but the alternative is the certainty of agency costs getting out of control because of what's happening to volume. Okay, team, really good, straightforward discussion, and that moves us, I think, segues us nicely into the numbers. Kim, over to you.
Thank you, Chair. So if I could, first of all, I need to ask the board for approval for a change in plan. And then I'll pick up some highlights around the financial position for the month 1 report. As Glenn alluded to earlier, we had set an original break-even plan that we submitted to NHS-IE, and that was subject to further discussions with them around inflationary pressures. We've obviously now had confirmation as to what funding they're providing organisations to cover inflationary cost pressures. And that takes the system closer to a break-even position. So if you recall, the system submitted a deficit plan in total of about £32 million. What that means is that organisations will then be required to resubmit the plan just before the end of June. We have been allocated £3 million of inflation and other figures, which means that I'm now asking the board to approve a resubmission of the plan to deliver a £3 million surplus. Just wanted to highlight as well that those inflation figures were not allocated on a fair shares basis, but they were based on individual organisation estimates of their inflationary pressures, which differ from organisation to organisation, depending on contractual arrangements they may have in place. Our estimate was not as high or not as significant as other organisations because we have good contract management in place. So I just wanted to reiterate that. I believe that once all organisations have discussed that the position with their boards, a number of organisations in the system would be presenting or asking for break-even or surplus plans, with the exception of one organisation which will continue to submit, I believe, a deficit plan with two digits in front of it. So that's the situation that we're in. So first of all, if I can ask the board to approve.
Just before we go to the approval, Kim, if it was on a fair shares basis, what would the £3 million be for us?
I haven't worked that one out, sorry. It'd be more than 3 million, sorry, because we got about 26 million in total for the inflationary pressures. And we're
of the fact that the fair shares number would have been higher.
It would have been higher.
I don't think we've got an option here apart from to approve this revised plan, whilst recognising the fact that the fair shares number would have been higher. Rosemary?
Can I just understand, Kim? We've been given this inflationary figures, but my understanding was that our original budget did not include the inflation that we are now seeing. So is it right that we're signing off a 3 million surplus, given that our costs are likely to be higher than at the stage of the budget?
Yeah, so the original plan, we were effectively trying to manage and absorb the inflationary cost pressures. So to break even, we as an organisation have set ourselves effectively a higher CIP target in order to close the gap. So if the funding comes, then the expectation is that we should be improving our position.
The other way of thinking about it, Rosemary, in my view, is we set ourselves a CPIP than others. And so the combination of us being demanding of ourselves in the first place, can I ask others to go to mute whilst people are talking? It's creating feedback. And then on a fair shares basis, we've been penalised there as well. So arguably we've been hit by a double whammy, but it is where it is. So like I said, I'm not sure we've got an alternative, but it is important to note those two elements as you indicate. So Rosemary, if I could ask you to take your hand down for me, please. So if you're not happy to approve the adjustment to the plan to allow for the adjustment for inflation and the additional income thereof, please raise a digital hand, albeit the minutes will note the 2 points we've just made about our higher CPIP in the first place and the fair shares allocation. Kim, for minute purposes, can you identify what that fair shares allocation would have been That's duly approved, as I can't see any raised hands in dissent. So Kim, back to you for the rest of the report, please.
Thank you, Chair. So against the month one position then, against the break-even plan, we are reporting a £625,000 deficit. The main driver really for that position is, again, the agency expenditure that we've kind of alluded to and discussed in the previous section, but also around the lack of CIP delivery. So in terms of agency spend, we have kept some additional capacity open during the April period. We also had obviously a number of vacancies and sickness that we were required to cover, and the safety of our patients is really important. In terms of, we also incurred expenditure in order to deliver the elective recovery performance as well. In terms of the CPIP, again, we're behind where we were. As you recall, we were still dealing with operational pressures. So the divisions have not had opportunities really to think about some of this longer term CPIP delivery, although we continue to drive productivity. I'm coming back for a board workshop session next month, but we've already been engaging with the organisation around productivity and also ways of supporting the divisions in CPIP identification and delivery. Having said that, we still remain, low cost. I've said before, our indicative reference cost is low at 88, but the formal publication of that is yet to be announced. In terms of where else are we? So elective recovery. Again, we talked about elective recovery earlier. So as we've discussed, the target that we're expected to achieve is 104% based on compared to the 2019-20 levels. And in that year, we performed really well, which means that the target is harder for us to deliver against, but we did achieve 90%. Now, we have assumed that we will receive the income for achieving that on the basis that currently we understand that the rules would be that there'd be a quarterly kind of review of the position, because the national monies is available, that it's got to go somewhere. So even if you don't achieve it, you will be given a share of that money. So we have assumed in our position that we will receive a relative share of that money. However, that is a risk at the moment because we haven't had formal confirmation that is the case. But that's what we have assumed. Our cash position remains strong at £41 million, and that's what I wanted to highlight specifically for this report, Chair.
Thank you very much, Kim. We're running a bit late now, guys. So any questions to Kim? Yeah, it's all about elective recovery and those agency costs. Kim, keep us briefed. On the mortality report, Charles, anything you particularly want to put out?
No, you'll see the 6-monthly report later on. Essentially, the mortality indicators remain within control limits. The medical examiner function is really going strength to strength. We now promised a national IT system, and I would note that the only indicator that is performing less well is the HSMR, but there is complicated methodological reasons why that might be the case, and it's still not statistically significantly an outlier. But I'll take any questions on that.
Okay, great. Any questions to Charles on the mortality report? Okay, moving on to you, Ali. Could you just pull out the key points, please, on the monthly safe staffing report for us?
Thank you, Chair. Well, I could take the report as read and happy to take questions if that helps with timings.
Okay, that's very helpful. Thank you, Ali. Any questions to anyone on the safe staffing report? Sorry, sir, after you.
Thanks, Chair. Yes, on maternity, I noticed that for both midwives and SCBU nurses, there'd been quite a change month on month. And I just wondered if those changes were expected and planned for in the workforce plan that was put forward a couple of months ago, or whether they are news.
So those ones are for existing vacancies, not the business case. Is that what you're thinking of in terms of planning? So those are existing, and then we'll have additional vacancies from the business case. You're on mute, Sue.
What I'm getting at, and I mentioned it at clinical governance, is that we're very proud of our service, and we know that staff are working incredibly hard to maintain that. So the speed that we can get those business cases through and those posts in role is important. So some of them are partly through, aren't they? Some of them have not yet started. So what I was trying to get at was, is this more vacancies on top of those that are still in the business case queue?
Do you want me to step in there?
Oh, hello, Maria.
Sorry. Hello. Just to say that some of the recruitment numbers for the midwives and the CSWs, we've already interviewed and filled those posts, and we've already got interviews set up next week for more maternity support workers and for midwives. So we are pulling our resources.
And recruitment's very healthy as well, isn't it, Maria? When you put posts out, you fill them. So that's not a concern.
Great, so thank you. Just that's assuring to hear that the pace is carrying on in getting those filled. Thank you.
Thanks, Sue. We've got maternity coming up on the next item. Ellie, what on staffing, apart from what we'll be talking about in maternity in a moment, any particular areas that worry you?
So we're continuing to focus on our unregistered staff currently, as being difficult to recruit and retain. So they're a key focus. We're having some CSW only face-to-face recruitment days, which have proved very successful, having our clinical teams there to talk to them, having our practice development there to tell them about pathways and apprenticeships, etc. So off the back of the first one of that, we've already recruited staff. We've got 15 CSW starting on Monday and more in the pipeline. So I think that position is sort of flattened out, and I think it's going to improve, but we are monitoring it because it has declined over the last year.
Okay, thank you, Ellie. And Glenn, and then we'll move on.
Yeah, if you go beyond nursing into some other disciplines, and ODPs in theatres are clearly an issue at the moment, and we've been looking specifically at recruitment and retention in that area, including something I'm taking to the charity trustee to improve the staff room within theatres to make it a nicer environment for the staff.
Okay, well, as I know the chairman of the charity trustees, it will probably be interesting for him to hear that. That's an in-joke for members of the public. I am the chairman of the charity trustees. So we'll move on then on to Maria and Ellie taking us through the Clinical Governance Committee, the Maternity Governance Quarterly Report. What points would you like to pull out, guys?
So this is a very detailed report, very honest report, and I'd like to highlight the visit that we had, the assurance visit following the Ockenden publication, which was very assuring around our leadership and open culture in maternity. There is a lot of detail in our action plans against Ockenden and saving babies' lives. And in the Chief Nursing Officer's absence, myself and the Head of Midwifery and the ADU are going to be meeting fortnightly just to keep some monitoring and traction on all those actions. As you can see, Maria is here today. We also have our ADO for Family Health and our AMD. So if anybody has any questions, I may defer to them.
Yeah, that's great. And I referred earlier, David and I had a really great visit to Skaboo yesterday, and good to see so many members of the team. One point I think is quite important for me to just say, which is regarding the way we score ourselves, if you like, against the Ockenden checklist. I always want us to be extremely self-critical and apologise and demanding of ourselves, rather than in any sense trying to mark ourselves up and potentially look better than otherwise we might. I mean, it is one of the nonsenses about the self-assessment system at the moment, but I'm very pleased that we are self-critical. So questions and perspectives on the quarterly report and to the team. Glenn, first of all, please.
Just well done on the insights visit, because these visits are taking place across all maternity services across the country, and I think you know, and I think actually they will change people's assessments of where they are in regard to Ockenden. But actually, you know, there's some really positive feedback there about the quality of the services, and kind of confirming some of the things we know we need to work on as well. So well done for that.
Oh, absolutely, and well said, Glenn. David?
Yeah, I mean, this is something that came out of our joint visit to Skaboo yesterday. The team were really keen to tell me that they'd just been awarded by an organisation called Bliss their gold accreditation, which Bliss is just an organisation nationally that is dedicated to babies that are born either premature or sick. And it's probably even more interesting to know that there's only so far 10 units in the country being given this accreditation, and Warwick Skaboo is the first in the West Midlands to receive it. I've actually seen the full report, and I have to say it's really glowing. I mean, I think I think there's 100% is the maximum, and of course nobody gets 100%, and the ladies, because they are essentially all ladies there, managed 97.3%, which I think we should commend. So I think I just wanted to make sure in public everybody was aware of that.
No, thank you. Well said. You want to come in on that? Ellie, did you want to come in on that?
Thank you. I was just going to say, in terms of the report and action plan and how we've marked ourselves, as Glenn says, we're being very open, we're honest about this. But just to be clear, what we're not saying is that we're not safe. So what we're saying is we recognise that we need to do these things to meet the Ockenden requirements. However, we are mitigating and we are doing things on a daily basis to keep women safe. So just to be clear on that, where you see red, it is something that we are working on and there are mitigations in place.
No, thank you, Ellie. And Charles?
Yeah, I just wanted to say that this question of transparency is really at the heart of Ockenden and all the previous maternity inquiries and those to come. That, you know, it was organisations with boards that didn't have inquiring minds, didn't listen to relatives, didn't recognise their problems, and therefore didn't address them. So, you know, doing all those things is absolutely what's required.
Absolutely, Charles. And Maria, before I go to Rosemary, you're recently with us. Are you happy with the level of board discussion that's occurring on all of these issues?
Yeah, I mean, as soon as I started, I could recognise there was great strength among the general side with Ellie and with Fiona, and for me that link it's outstanding, and I think that helps with the whole process of the reporting up to board, and I feel that you have good oversight of everything that's going on, and you know, you do respond to what we're saying, which is for us, you know, we really appreciate that you're listening to us when we're saying actually we need X, Y, or Z, or we need that financial support, and understanding that, you know, we're doing this in response to the safety measures that we have to put in place.
Thank you, Maria. And Rosemary?
Yeah, I just wanted to completely concur on the openness and transparency around Ockenden. Where I find the challenge is on the clinical negligence scheme for trusts, which is the first part of this report. You know, again, we've been very open and honest about that. But my concern is that we are being penalised compared to some other trusts, because this results in pounds and pence coming or not coming back to us. And I'm not sure quite, I mean, we are talking quite significant sums of money involved in the maternity incentive scheme, I believe. I mean, Ellie and Kim, do you know how much it was this last year?
Sorry, think what, sorry?
How much the maternity incentive scheme is at stake?
Not to the top, not on the top of my head.
We're talking six figure.
Yeah, the actual total scheme is six figures, but in terms of when you achieve certain levels, the benefit, I can't even think of the word, back is slightly smaller, so it just depends. So I can get you the breakdown if that's okay.
Yes, no, I'm just thinking, you know, at the present time, whether we should be putting pressure on, you know, the clinical negligence scheme to consider changing its ways, because it seems an inappropriate way of funding.
I concur on the point on funding, but I think it's incredibly important for the frontline teams to score in the way they see it, without any regard to the financial implications.
Absolutely, and therefore we shouldn't be getting incentivized funding wise around this. We should be working a different way.
Maria, did you want to come back in?
I was just going to agree. So the scoring that we've done is the position we're at now. However, as we move forward towards the submission date, we'll be pulling the evidence that we need. So it's once we've got that evidence in place that we'll then say, yes, we are meeting those standards, rather than no, we're not meeting them, we won't meet them. We're working towards.
You are okay. Yeah. Excellent, because that's, you know, it is quite important for the trust actually as well to achieve this.
Yeah, definitely.
Okay, thank you.
No, really great work, team. I'd just like to make two general points about health and well-being. Maria, if you disagree with me, or Ellie, you disagree with me, please don't hesitate to say so. Just in terms of the health and well-being of mothers and babies, members of the public may not be aware, but a third of the mothers who attend our maternity unit, roughly a third, are on some form of antidepressant drug when they are pregnant and give birth. That is a tragedy, obviously, for the mothers, but also in terms of the babies once they're born, it does mean two things. They stay with us for longer, and it is a far more intensive monitoring regime that we have to undertake. So I'd really encourage primary care colleagues in our geography to be working with patients as to how best they can manage their own treatment regime as they come up to the end of pregnancy. The second is the enormous increase in BMI amongst pregnant women in Warwickshire, which again has real consequences on the safety of their pregnancy and the well-being of baby. We've talked in the past a lot about smoking cessation in regard to the welfare of mothers and babies, but I'd just like to emphasise again the need for us as a society and us as an anchor institution to help mothers with very high BMIs, which will not be good for their well-being, and it isn't good for babies' well-being. Ellie and Maria, if you disagree, please say so now.
No, I mean, if that mirrors obviously with the raised BMI, the high levels of women with diabetes that we're getting through our service, and then, you know, not only the ongoing concerns for them and their baby, but the ongoing concerns for us financially providing that care, because it's high level care that they need. So yeah, it's, if we can kind of step in with all our partners and look at health and well-being and trying to help reduce, if we can, those numbers.
Absolutely, Maria. And here's one of the great things about the work we're doing at Place and the integrated focus we have with our community teams. that we will increasingly in the future be able to focus on prevention. Ellie, Maria, rest of the team on the call, thank you for joining us. Thank you for your hard work, and send our regards to everyone on the front line. I'll move us forward now because we are running quite late. The Clinical Governance Committee report for the 11th of May. David?
Yeah, I'm happy for it to be taken as read and answer any questions anybody's got to ask.
That's good. David, any questions to David? Okay, thank you, David, and thank you to everyone for your hard work on that committee. The Patient Experience Annual Report for Q4. Ellie, you're earning your salary today. What would you pull out on this?
Okay, so just a couple of things really. Just that we're really happy to say that our learning disability support worker has started in patient experience, is already going out onto the wards and is providing us with some valuable feedback. So we're really delighted to have that role in. And just for the eagle-eyed amongst you who may have seen that the PALS referral rate has gone up and might have thought to ask about that, just to say two things really. It's a shame the graph isn't longer, because that kind of PALS response rate is what we would have seen pre-pandemic, so it's basically going back up to where we would expect it to be. The other thing I'd like to say is that, you know, we need to remember that PALS contacts aren't a negative thing. The purpose of patient advisory service is that people contact them, so the more people contacting them asking for advice and support, the better. So just those two things really.
Thank you, Ellie. Any questions or perspectives to Ellie? Okay, thank you. Very clear, and you're absolutely right on the PALS point, Ellie. So the 6 monthly update on trust performance against national guideline on learnings from deaths. Charles?
Yes, really, there isn't a lot to add from the mortality report. The indicators remain within control limits. The medical examiner for death function is working well. There is, compared to the SHIMI and the RAMI, the HSMR, which is a similar indicator, is less favourable but within control limits. And we are looking into some depth as to why that might be. You will see that actually compared to the other trusts in the group, that they have had the same trend, but ours slightly less so. But any other questions I'll happily take on this.
Thank you, Charles. Any questions to Charles on the 6th monthly update? Okay, thank you, Charles. And as you said, we have seen those numbers pip up in the rest of the foundation group. The CQC update, including the insights report. Back to you, Ellie.
Can I take this as read? So this is the quarterly report, and it was published in January, and it's data from November last year to the 12 months.
That's great. Thank you, Ellie. Any questions to Ellie on the insights report? On the CQC update? Okay, so I think we're on to the report from the Council of Governors, which I will take as read. It's great to see so many new governors join us, and the enthusiasm of the new governors to get involved in the various different subcommittees. Some really great experience from different new governors to join the stalwart governors who have been with us many years. Any questions on that Council of Governors meeting held on the 12th of May? Okay, so I think we're then on to summary of ratified policies. Sarah?
Thanks, Russell. Happy to take the report as read. Thank you.
Any questions on the summary of ratified policies? Okay, duly noted. Thank you, Sarah. And then we've got the update of, the summary of reports for noting and information. Kim and Gertie.
Thank you. So just a couple of points to draw out, if you don't mind, for the CSIRO. So I'm a Deputy CSIRO now. Anne has been appointed the CSIRO following and took over from the Chief Technology Officer back in October. So this is the annual report that sets out progress against implementation of the IG agenda and information risk management processes. positive report, obviously culminating in us achieving the and meeting the standards for the data security toolkit. So positive report, and I think that's all I wanted to draw attention to.
Thank you, Deputy Silo. And any questions to Kim? Okay, thank you, Kim. And then we'll move on to the health and wellbeing report, Gertie.
Thank you, Chair. This is the first report we've produced, and I'm hoping to spend some time with Sue in the coming weeks, just in terms of her insight from the Health and Wellbeing Guardian to improve this moving forward. Health and wellbeing continues to be really important to the delivery of our safe, compassionate, trusted, inclusive care. And we know that if we nurture our staff and provide them with healthy environments, they will provide better patient care. So it's a key area for us. There's a summary in there of some of the great work that's been undertaken in the past year or two, and obviously sets out the work that the priority areas for us of financial hardship, menopause, the restorative programme, and aligning ourselves with the national frameworks over the coming year. We're also leading the system people board subgroup, so our health and wellbeing lead is undertaking that, and we will be seeing some connectivity where we can share and do work at system level. I'll leave it at that, Chair. We're more than happy to take any comments or questions.
No, great to see this as being the first of many reports, so thank you, Gertie. Any questions to Gertie on the health and wellbeing report? Okay, so we'll move on then to the updated, oh sorry, Glenn.
Sorry, I was a bit late. Gertie, just on the issue of supporting staff around hardship, I had a really good conversation with the non-execs this morning. I think one of the things that we would be interested to explore is whether we could strengthen our links with Citizens Advice and maybe get some more activity brought into the organisation direct to staff on that. That would be really helpful.
That's already in hand, Glenn. We're trying to link that together, and we are connecting up with wider than just Citizens Advice, so banks and other financial institutions that can give advice and support, and we'll be doing that locally, but between us and George Eliot and that system as well. So absolutely one of the things that we are looking at doing. And there's also a paper going through next week to the charity trustees around developing our own internal hardship fund. And I'm hoping the chairman might have a word with the chair of the charities committee on that as well.
Thank you, Gertie. He may well do. Sophie?
Yeah, it was just to say, what I'll do as well, guys, is I'll link up your environmental one, because we're getting a lot of requests in the last couple of months for staff wellbeing areas. I think Glenn referenced theatres earlier, and there's some of the things actually that staff are reporting are really impacting on their wellbeing. We've got a couple more, so it's just some oversight for board, and some of that I'll add in to this as well.
Okay, super. Thank you. What's been the feedback on the new car park, just as an aside, just sort of related to staff wellbeing?
I think no feedback, no complaining. Claire's on the call, but we've seen no complaints about parking, which is the recipe for success, really.
Okay, no news is good news. Glenn?
Yeah, they're using the chargers, the electric vehicle chargers, so staff. So there is plenty of room, so nobody can say there isn't somewhere to park nowadays. So it looks good.
Yeah,
okay.
for the first time in my 39-year career in the NHS, I've gone through a period of several weeks without anyone complaining that they can't park, which I think is a significant development.
Absolutely. Thank you.
Great, thank you. So we'll move on then to the updated register of directors' interests. Sarah?
Thanks, Russell. So this just captures David Spraggett's update, his new declaration, which he declared earlier on in the meeting. So happy to take as read. Thank you.
Okay, great. Any questions on the updated register? Okay, super. So we'll move on then to the board committee minutes. The first is the Clinical Governance Committee of the 13th of April. David, anything you'd like to add to this?
I don't think so, no.
Okay, thank you, David. Any questions to David? Okay, I'd just like to say, David, it's been almost a seamless transition from Bruce to you as Chair of Clinical Governance. So, and I know you are incredibly busy in the day job. So thank you very much for your commitment to us as an organisation and the citizens we serve.
Yeah, Bruce took a lot of time trying to help me along. I have to say, I must give him some credit, even though he won't be listening to this.
You never know. You never know. It may become a podcast of interest for the future our board meetings.
I hadn't thought of that one, I must admit.
So, any other business, colleagues? Please raise a digital hand if there are any other points of business. Okay, I can't see any hands raised, so thank you. So, questions from governors or members of the public. Sarah, have we had any come to us?
No, we haven't had any submitted. Thank you.
I'll just, for a couple of minutes, invite any members of the public who might want to ask a question to raise a digital hand. Okay, I can't see any digital hands raised, so thank you all very much for joining us. Look forward to seeing you at our next meeting, which is, apologies, on the 6th of July. So look forward to seeing you all, if not before, on the 6th of July. For board colleagues, I suggest we take a 10-minute break and get back together again at 3:40 for the confidential board. Thank you very much, ladies and gentlemen. Take care.
Thank you.